Okay, so we're talking about disorders of the hematologic system, and mostly what I'm going to go through is uh, anatomy, physiology, things you need to know about the function of the cells, where do they start, what do they do, that will lead you into an understanding of the disorders. So this slide kind of talks about or shows some of the organs that are involved. And so here we have the kidneys. And you may be wondering, well, what does the kidney have to do with red blood cells or any cell production? Well, you can see here we have low blood oxygen. What that means is that when the kidneys don't receive adequate oxygenation, whether it's from decreased volume to the kidneys or the hypoxia for whatever reason, whether it's low atmospheric pressure or low oxygen in the atmosphere, the patient has a respiratory disorder, short-term or long-term, like COPD, this signals the kidneys to produce erythropoietin. Now, erythropoietin's job, if you will, is to stimulate production of red blood cells. So where does that production occur? Well, the production of cells that belong in the hematologic system, such as red blood cells, white blood cells, and platelets, occurs in the bone marrow. So, but erythropoietin's function is to stimulate red blood cell production. But all blood cell production occurs in the bone marrow. Mostly in flat bones, say the sternum. This is showing a bone of the vertebrae. Long bones, such as the femur. Other flat bones would be like the iliac crest, the pelvic bones. So this is kind of specific this picture specific for red blood cells. So it gives you a little bit of information about red blood cells, such as the normal red blood cell has a lifespan of 120 days. Well, what happens to the red blood cell after that 120 days? Well, it's removed it's broken down in the liver or the spleen. And when it goes to the spleen and it breaks down into its component parts. So we have heme, which in this case is not an engine, and globin. Well, globins are amino acids. So they're broken down, and you can follow the arrow and you see that it's reused. So the amino acids are reused, and then the heme is also broken down further, and it's broken down into iron, which is reutilized to make new red blood cells, and bilirubin. Bilirubin then goes to the liver, where it's further processed and excreted into the small bowel. So if the liver isn't working appropriately, then we get the bilirubin not broken down. Well, what happens to it? Well, it's sent then into the intestines, where it isn't excreted, and it's reabsorbed into the system. And how do we know that? Because we can see it. It has a yellow color, and it's deposited in the skin, in the sclera, and that tells us that we have liver problems. So the bilirubin is not being broken down, and we see that as jaundice, or that yellow of the skin and eyes. So what else does this tell us? Well, it tells us then that, if we could back up a little bit, that we need iron and we need proteins in order to make red blood cells. And we need erythropoietin to stimulate red blood cell production. So back to the intestines, we see that they're in the small intestine here. We have areas that are important in the absorption of iron, the absorption of vitamin B12, which you've already talked about in Unit 7 in Foundations, and the absorption of folic acid. The liver also plays a role in the usage of folic acid. And so we go back to the liver again, and you want to think about what kind of conditions would alter the function of the liver. And of course, the most obvious one would be alcoholism. So individuals with alcoholism or liver damage for whatever reason, whether it's cancer or medications, are going to experience a decrease in the absorption and utilization of folic acid. Individuals who have diarrhea, or they've had portions of their small bowel removed, are going to have problems with absorption of folic acid, vitamin B12, and iron. And individuals who have significant ulcerations of the stomach, or they've had portions of their stomach removed, are going to have difficulty with the absorption of vitamin B12. Because remember, vitamin B12 relies on that intrinsic factor for absorption. So these are the nutrients that are needed in order to produce red blood cells in the bone marrow. So again, just to show the components of the blood, primarily we're talking about the cells, but the cells make up a relatively small portion of circulating blood volume. A large portion of the blood is plasma, and plasma is kind of the liquid that the cells of the blood are suspended in. So what are the cells that we're primarily interested in? We're interested in red blood cells, white blood cells, and platelets. So you can see that plasma makes up approximately 60%. Some sources say 55%. Some may say 65%. The cells make up approximately 40%. So 35 to 45% of the cells, of the blood components, are the cells. And we're not really interested so much in breaking it down much further than that. But what this is showing is that if I allow the cells of the blood to settle in a tube of blood, then the red blood cells are heavier and they fall to the bottom. And then the white blood cells and the platelets kind of float on top of that. And then the plasma, is going to have proteins and fluid in it, make up the rest. So, let's talk about red blood cells. Red blood cells are the cells of the blood that function to carry oxygen and carbon dioxide. So that's their primary role. And you can see here that another name for red blood cells is erythrocytes. You want to learn that name. you'll see lab results, you'll see this term utilized, and you need to know that it means the same thing as a red blood cell. Look at this red blood cell, and what do you notice about it? It looks kind of like a closed donut. So what we call that is a biconcave disc. So on both sides, it is kind of sunken in, if you will. And it's like this for a reason. That shape allows it to bend and fold and become smaller so it can move through the smallest capillaries of the circulatory system. So it's a biconcave disc. It also increases the surface area. So there's more area for the red blood cell to hold oxygen and carbon dioxide. And this is very important. It allows us in times when we have, for whatever reason, fewer red blood cells to still carry adequate oxygen throughout the body. This is kind of showing you the process. So within the red blood cell, we have hemoglobin molecules. Now the hemoglobin molecules are what's responsible for attracting the oxygen. And so these oxygen molecules from the lungs are attracted to and attached to the red blood cell. And then the red blood cell travels through the body and releases the oxygen wherever it's needed by the tissues. At the same time, as it releases its oxygen, carbon dioxide then attaches to those red blood cells and travels back to the lungs, where the process is started over. And I put this little graph on here just to show you, remind you, or revisit the nutrients needed. So iron, here's our green leafies. Again, remember that's always the answer. Green leafies. Organ meats are good sources of iron, but you can get it from vegetables. Our body doesn't utilize iron from vegetable sources as well as it does from meat sources. However, we also know that organ meats especially have a lot of cholesterol and fats that we don't need. So we just have to increase our intake of green leafies. You can see that folic acid, which is vitamin B9, comes from beans and legumes. Other B vitamins come from, again, our green leafies, avocados, which are awesome source of B vitamins. And then, of course, we need vitamin C. Vitamin C is always important in growth of tissues. So it is an essential vitamin. The other thing you want to remember about your B vitamins and vitamin C is that they're water soluble, meaning our body doesn't store them and we need fresh sources of them every day. Iron, on the other hand, is somewhat stored. That doesn't mean we don't need it on a daily basis. So just to recap, red blood cells contain hemoglobin. Hemoglobin transports oxygen to the body tissues and helps to carry carbon dioxide from the tissues. And how is that process started? Anything that causes hypoxia is going to stimulate erythropoietin. And where's erythropoietin? Correct, the kidneys. And it stimulates the bone marrow to make more red blood cells. Now, this process doesn't happen within minutes or hours. It takes 3 to 5 days for this process to occur. And so it requires these nutrients and proteins in order for a good, normal, oxygen-carrying red blood cell to be made. Again, the lifespan is about 120 days, and the iron and the amino acids are reused, and requires functioning spleen and a functioning liver for the process to be done appropriately. And a byproduct is that bilirubin that is excreted in the intestines or can accumulate in body tissues. A leukocyte, also made in the bone marrow, is a white blood cell. Now we have all these different types of white blood cells, and really leukocytes is not the purpose of this, but I just wanted to take a moment to point out that it is made in the bone marrow. It's part of the hematologic system in that circulates in the blood. It's a blood component. It's part of the defense system, helping us to fight against infections and disease. So sometimes the things that affect red blood cell production are also going to affect white cell production. And so in that sense, we always have to keep it in the back of our mind, even though it's not really the focus of this unit. Lab values for white blood cells and would be our white blood cell count. Again, I don't want you to spend a lot of time on white blood cells. So, and then we have thrombocytes. Now, thrombocytes are platelets. They're part of the coagulation process. They're also produced in the bone marrow. So you can see that when not in use, they just look like flat little discs. And then when they're activated, they send out these finger-like projections, and they kind of plump up, and that makes them a little bit bigger. And they kind of are the first line of defense to prevent bleeding. I put this coagulation cascade, not so much that I want you to memorize all of the factors, but you can see that there are factors from 1 through 12 involved in the coagulation cascade. And we have the intrinsic pathway and we have the extrinsic pathway. And the intrinsic is the partial thromboplastin time, and that's how we evaluate it. And the extrinsic is the prothrombin time, which is how we evaluate it. So those are lab tests. And you can see that we have prothrombin and thrombin are factor 2, and then factor 1 is fibrinogen. And fibrinogen is one of the one of the first things that occurs right behind platelets. So platelets, when activated, kind of clump up together, and they're going to plug this hole. And then we have fibrinogen that comes in, and it's this stringy stuff that makes a web or a net, and it begins to trap the platelets that have been activated and begin to form that clot. And so you want to think, what happens if I don't have adequate numbers of platelets? What happens if one of these factors are missing or doesn't function properly? Well, I think the easy answer then is that bleeding occurs, because this clot is going to be, it may start, but then it's unstable and it never completes. And so it can break away or bleeding occurs around it. The other thing that this picture is showing is that initial injury to a vessel causes vasoconstriction. And that works fairly well if it is in a vein, especially in a small vein or arterial as opposed to a larger artery. In a larger artery, sometimes vasoconstriction can make it worse, simply because it doesn't occlude. It can open up the gap. So for platelets or thrombocytes, our concern is bleeding. So we're going to look at labs that check the platelet count. How many platelets are there? How many platelets should there be? So we should have, depending on the resource that you look at, 150,000 to 400,000 platelets is normal. Bleeding time is done by putting a blood pressure cuff on, and then they make a little cut and use some blotting paper, and they're counting the seconds till it stops. Prothrombin time, which is your PT or pro time, is again checking for the external or extrinsic clotting factors. And we also use it as a means of measuring when a patient is on Coumadin or anticoagulant therapy. Same with INR. INR is measuring the pro time, and it's a useful measure for clotting factors or for Coumadin therapy. The partial thromboplastin time is intrinsic evaluation, useful for measurement of heparin therapy. And the thrombin time is checking whether fibrinogen is converting to fibrin. So remember that fibrinogen is your clotting 1 factor, and it converts to fibrin, and it makes those long stringy fibers that form the base of the clot. So that's what thrombin time does. So let's go back and look at this. Bleeding time normals should be 2 to 9.5 seconds. So the maximum amount of bleeding time we want is 9.5 seconds, unless they're on an anticoagulant. Prothrombin time normal is 10 to 13 seconds, unless they're on an anticoagulant. INR normals are 2 to 3.5. And this will depend on whether or not they're on therapy. So depending on if they're on Coumadin therapy, then we want longer or higher INR. but typically 3.5 is over. Anything over 3.5 is more than adequate therapy. We want to cut down their dose. Partial thromboblastin time, normal is 25 to 35 seconds, and normal thromboplastin time or thrombin time is 24 to 35 seconds. Okay, so I'm backing up because for whatever reason I skipped this slide earlier, and I don't know how that happened, but it did. So I wanted to be sure and go through it. So red blood cell count is relatively obvious. We're looking at the number of red blood cells in a volume of blood. Again, depending on your source, it's going to vary a little bit. So red blood cell count is 4.2 to 5.4 million per milliliter, I believe, but I could be wrong on that. For men, and for women, normal red blood cell count is 3.6 to 5.0 million. Reticulocyte count is a measurement of new red blood cells. So these are ones that are immature or relatively young, and gives us a good indicator of how well is the bone marrow functioning. So if we have a patient that has anemia or has significant hypoxia over a long period of time, is the hematopoietic system compensating? Is it attempting to make new red blood cells to deal with the increased need to get oxygen throughout the body? It also can indicate problems, so that if we have too high of a reticulocyte count in the absence of hypoxia or decreased numbers of red blood cells, then, of course, that can indicate that we may have leukemia or something, and the bone marrow is not functioning, and it's sending out too many immature cells. And then the hemoglobin, you can already see the importance of hemoglobin. And just because we have adequate number of red blood cells doesn't mean that we have adequate hemoglobin. So we have to look at it as well as the red blood cells. This gives us an indicator of perhaps the type of anemia that we have. So if we have adequate number of cells, or maybe even an increased number of red blood cells, but the hemoglobin is low, then that can be an indicator of the type of anemia that the patient is suffering from. So normal values for hemoglobin for men is 14 to 16.5, and normal values of hemoglobin for women is 12 to 15. So think about the function of the hemoglobin. Remember that the hemoglobin is the oxygen-carrying portion of the red blood cell. So if I have a low hemoglobin, what symptoms if my patient has a low hemoglobin, what symptoms am I going to observe? What is the patient going to complain of? And this is my first clinical observation that tells me my patient may have a problem of the hematopoietic system. It's also going to lead me to my nursing diagnosis. So think about this. Why would my patient with a low hemoglobin have a nursing diagnosis of impaired tissue perfusion. So think about that, and that's one of the things that you're going to hopefully figure out in class if you haven't figured it out already. Now, hematocrit is a percentage. It's a percentage of the hemoglobin per red blood cell. So it gives us a little different look at what's going on. The normal hematocrit for men is 40 to 50%, and the normal hematocrit for women is 37 to 47%. So, ask yourself, can I have normal red blood cells count, but a low hemoglobin? Does that necessarily mean that I'll have a low hematocrit? Can I have a normal hematocrit, but a low hemoglobin? And when would that occur? And again, that's going to give you some indicators of the disease process that your patient is experiencing. So let me flip through some of these. Now, some terms that you need to know include the suffixes penia and cytosis. So penia typically means low, and cytosis typically means production of. So if I have erythrocytopenia, what does that mean to you? So you have to break down the word. Erythrocyte is, hopefully you said red blood cell. So erythrocytopenia is low red blood cells. Whereas erythrocytosis is going to mean overproduction or production of red blood cells. Some other terms that I don't have listed here would be lysis. What does lysis mean? It means destruction. So if I have hemolysis, hemo meaning blood, then that means destruction of red blood cells. Now, this could be a normal thing after the 120-day lifespan, or it could indicate a disease process. If my spleen is not functioning appropriately, or my liver, then I may have hemolysis or hemolysis that is occurring on cells that would still be functionable. I don't know if that's a word, but I'm throwing it out there to you. So hemolysis can occur after the 120 days. And remember, what does it release? Ask yourself, what are the component parts of the red blood cell, and what happens to those? Because again, that could be an indicator of disease process. Anemias typically mean too few red blood cells. We should probably revise that to mean too few functioning red blood cells. If we focus on what is the function of the red blood cell, and that is to transport oxygen and carbon dioxide. So how can a red blood cell not be functioning? Well, if it doesn't have adequate iron and heme, then it's not going to carry the components that it needs to. So therefore, it's not functioning. I can have too many red blood cells and still suffer from an anemia because the cells that I have aren't good. Additional terms would be chromia which has to do with color. Typically in class, you would get to listen to me sing, because I just kind of skipped past it. But chromia always makes me think of the song by Simon and Garfunkel, Kodachrome. So if you've not heard that song, you can look that up and see where I'm going with that. So if we have hypochromia, what does that say to you? So if chromia is color and hypo is low, then we have low color. So this is what we call pale cells. Now why might they be pale? What's giving them the color? Well, the iron and the hemoglobin gives them the color. So pale cells are going to be associated with iron deficiency anemia. So there's a clue. So what does my patient need? Well, they need their green leafies and they need their organ meats, correct? All right. So you can run with that. So normochromic is going to mean they have normal color. They're the red color that they're supposed to be. What about normocytic? Cytic means size. So normal cell. So if we have normocytic, they're the normal size. If we have hypocytic, then they're small. So if we have small pale cells, what's wrong with that cell? If I have a hypocytic, hypochromic cell, what's wrong with that cell? And is it going to do its job? Well, it's small and it lacks hemoglobin, so no, it's not going to do its job. Another term that goes along with red blood cells would be polycythemia. So, excuse me. So poly meaning more or too many. Cythemia, cythe meaning cells, and emia meaning blood. So we've got too many cells in the blood. And here we're primarily talking about red blood cells. So let's go back again and talk about and think about the red blood cell. So the red blood cell is a biconcave disc. And why is it biconcave? Partly because it increases the surface area, more places for oxygen to adhere. Partly because it allows the cell to fold and twist and bend to get through those small capillaries. Well, what happens if we have too many of those? It's kind of like when you're in a big city, which I personally try to avoid, but you have an exit ramp. And the exit ramp starts out 3 lanes. And by the time you get down off the exit ramp to where you need to get onto the next 3 lanes, it is congested to 1. So what do we get? We get backup. Well, the same thing is going to happen in the capillary system. So I have large vessels narrowing down to smaller vessels, narrowing down to capillaries, which only allow a single cell through at a time. So now what happens? Well, I've got a backup. Well, red blood cells aren't the only thing in there, and so I've got congestion. And I'm going to get backup. So think about now what's going to happen when those capillaries are clogged. What happens when I don't have adequate blood flow and pressure builds up in the capillaries? I've got that plasma, but that fluid that has to have somewhere to go. So it's going to leak through and into the tissues. So at the very least, I might get some swelling. But I've also got the platelets. And platelets, they like to be free moving. They don't like to sit still. When they sit still, they get all sticky, cranky, and crabby, and they start fussing with each other, and they puff up, and they send out their feelers, and they attach to whatever's around them. And now what have I got? A clot. So I have, with polycythemia, I've got lots of issues that I need to deal with. So take a minute or two and think about what happens to cause polycythemia. Well, to do that, we've got to go all the way back to the kidneys. And whenever we have an insult to the kidneys, where there's not enough blood oxygen to the kidneys or hypoxia, then it sends that signal to make more red blood cells. So it can become a vicious cycle. But polycythemia itself refers to excess red blood cells. Purpura and petechiae are terms that go along with platelets. Purpura is essentially a bruise. It's a spontaneous bruise. By spontaneous, I simply mean that it isn't accompanied by trauma. So the patient can go to bed at night, not have any bruising, and then wake up with multiple bruises. They're frequently in areas that you don't associate with trauma. The middle of the upper back. Places where people don't naturally just hit themselves. And they're typically out of proportion to any type of trauma. And so, again, it's associated with platelets. And what is the role of platelets? To cause blood to clot. So, for some reason, we're not having blood clotting. And then petechiae are small pinpoint areas of hemorrhage. And they can look purple, they can look bright red. But with purpura and petechiae, there's no swelling. Often there's no discomfort associated with it, like you would expect if there were some trauma. Purpura is usually greater than 3 millimeters at least. Petechiae less than 3 millimeters. So something to be on the lookout for. So when assessing for hematologic disorders, we're going to do a skin assessment. Obviously, we just talked about purpura and petechiae, so that's some of the things that we're going to look at. We're also going to look for signs of easy bruising or ecchymosis. Ask about ease of bleeding. Are they do they bleed for an excessive amount of time from the smallest scratch? Look at the color and the temperature of the skin. What color do you expect if the patient is anemic? Do we expect a nice pink color? Do we expect it to be warm? What happens when we have inadequate blood oxygen? Well, one of the things that's going to happen is that the body shunts blood flow to essential organs. So if the anemia is acute, or if it's significant anemia, then the patient is going to be cold and pale. Cardiovascular system. Again, I think you can figure this out if you just take a few minutes and think about what is the function of the hematologic system. Well, red blood cells carry oxygen. White cells, immune defense, and platelets are for hemostasis, to prevent bleeding. So, if I have an anemia, what is my body going to do to overcome that? So with anemia, I've got low oxygen carrying capabilities. But the cardiovascular system's role is to carry that oxygen carrying red blood cell throughout the body. It doesn't know that the oxygen carrying capability of the red blood cell is not there. It just knows its job is to circulate oxygen. So what do you think the cardiovascular system is going to do? So hopefully you went somewhere that, and I know I probably didn't give you enough time to answer, but hopefully you're thinking along the lines of a change in heart rate. And that change in heart rate is going to be an increase. The body wants to circulate. If it can't circulate adequate oxygen, then it's going to say, okay, if one beat isn't enough, then I'm going to have to do 2 beats. So we're going to increase the rate, the heart rate, in order to circulate more volume. So as far as the heart's concerned, the cardiac output is down, and it's going to increase the cardiac output by increasing the heart rate. It may also dilate vessels, which is going to initially allow for freer blood flow. But if the anemia is prolonged or significant, it's going to constrict in order to preserve flow to essential organs such as the brain, the heart, the kidneys. Now, the respiratory system is essential in oxygenation as well. So, if the body isn't getting enough oxygen, the heart rate is going to speed up. Well, what do you think is going to happen to the respiratory rate? Because each of these things work independently as well as interdependently. So the respiratory system says, hey, I'm getting a signal that there's not enough oxygen. It doesn't know that the reason that there's not enough oxygen is because there's not enough red blood cells or there's not enough hemoglobin. All it knows is there's not enough oxygen. So it gets this signal, and its job then is going to be to bring in more oxygen. And so how is it going to do that? Its only recourse is to increase the respiratory rate or increase depth of respirations, or both. So we're going to see an increase in heart rate. We're going to see an increase in respiratory rate. Patients are possibly going to complain of dyspnea, fatigue, that sort of thing. Gastrointestinal. Now, frequently we're going to see that we have a change in gastrointestinal function. If the anemia is significant and prolonged, and blood flow is shunted away from non-essential areas, then I might see constipation. But what if the reason for the anemia is because I've got blood loss? What kind of changes in the GI system might I see? So I'll let you ponder that. We know that the renal system's role is to stimulate red blood cell production, and it does that as a result of hypoxia. So most of the symptoms that we're going to see, are you seeing a theme here, are as a result of hypoxia. Neurologically, the brain requires significant amounts of oxygen to function. So what are we going to see if we don't have adequate oxygenation? We're going to have fatigue, we're going to have confusion, irritability, all those things that you and I experience on a day-to-day basis as a related to stress is also going to be related to hypoxia from inadequate oxygenation due to decreased functioning red blood cells. Now, each of these will be a tiny bit different if we're looking at platelets. So with integument, I'm going to see the purpura, the petechiae, easy bleeding. Cardiovascular, more likely to see, possibly see clotting or inappropriate clotting, edema from bleeding into tissues, respiratory, possibly a clot in the lungs. It just depends on what the problem with the platelets are. So those are just some basic assessments. Is it all inclusive? Absolutely not. But it's the very basics that you're going to see based on thinking about what is the problem. And it's that thought process that's going to help you determine what is going on with your patient. And then you can add in those things that you just have to kind of memorize. But always, if you go back to what is the purpose, the why would this be happening, then it's easier to remember because you can follow that process along. So I'm not going to go through each and every one of these disorders. That's the purpose of our class time. But I just wanted to touch on them and get you pointed in the right direction. So we have anemias, we have polycythemia, we have thrombocytopenia, hemophilia, and disseminated intravascular coagulation. These are some of the things that we're going to talk about in class. So we can have blood loss anemia. I think it's fairly self-explanatory. If I'm losing red blood cells because I'm bleeding, then that's a significant source of anemia. But there can be multiple reasons for blood loss, not always obvious. And one of my roles as a nurse is to determine what is the cause of the anemia. I'm looking for those clues that I can give feedback to the provider to help them determine the best course of action. So, how does blood loss anemia look different from iron deficiency anemia? I'm hoping at this point you understand what iron deficiency anemia is and what it might look like. What is the basis for it? Obviously, the basis is an inadequate intake of iron, and iron is essential for production of red blood cells. Pernicious anemia involves the need for vitamin B12, folic acid deficiency anemia, because we need folic acid, and what kind of people are going to be at risk for that. Chronic disease anemia, patients with cancer or treatment of cancer and other kinds of chronic diseases are at risk for anemia for multiple reasons. Aplastic anemia, this is involving disorders of the bone marrow itself, where the blood cells just aren't being produced. Hemolytic anemias, such as sickle cell. And I have a couple of pictures on here that demonstrate sickle cell. So the hemoglobin in sickle cell is different. So normally you can see that the hemoglobin is rounded and it changes and adjusts and molds to the shape of the red blood cell. But in sickle cell anemia, the hemoglobin is abnormally shaped. So with trauma, such as squeezing through a small vessel, or hypoxia, or anything that causes hypoxia, such as dehydration or hypovolemia, the hemoglobin changes to a rod shape or a sickle shape. So you can imagine how difficult, because this shape of cell is not going to bend and fold to get through these small vessels. It's going to clump up, and that's going to cause all of the problems that we see with sickle cell anemia. Thalassemia is a genetic disorder of blood cells production, and acquired hemolytic, some outside process has caused destruction of the red blood cells. Polycythemia, we've talked about. Thrombocytopenia, what is a thrombocyte? That's your platelets. So we have low platelets, and this is frequently a result of medications, poisons, environmental factors, outside sources. Hemophilia is also a genetic disorder. Most of you probably know that hemophilia is an X chromosome disorder, and it's carried by the female and is presented in the male. Symptoms are. Sorry, I had to stop because my family's laughing at me. All right, so hemophilia, X-linked autosomal recessive disorder. So girls are carriers, boys usually have the disease, and they lack clotting factors so that they bleed freely. And then disseminated intravascular coagulation. So disseminated means widespread, intravascular within the vessels, and then coagulation obviously means clotting. Here's the deal with DIC, in that it's inappropriate clotting. It's clotting when we don't want or need clotting, and it uses up all the clotting factors. So now we've used up all the clotting factors, and so we have excess bleeding. So this is really a significant disorder, and if you look at the extended PowerPoint, you'll see that one of the slides says death is coming because of not recognized and treated early, the patient will bleed to death. So that's just a quick overview of some of the disease processes that we're going to discuss. And I think this is the last slide, honestly. I'm not sure. So anyway, this is the information I really wanted you to have coming into class on Monday. And while I know it's not enjoyable, I hope it was informative, and I will see you Monday. Oh, one last thing. Just a concept mind map kind of thing I came across. There's a lot of stuff on here not all of it that you need, but certainly I think that it um, breaks down, it gives you an idea of what you can do. So here we have blood, plasma, what is in the plasma, erythrocytes or erythro for red blood cells, leukocytes for red white, thrombocytes for the platelets. Not sure what this person means by forma, but anyway, bone marrow, what does it have to do with blood? And so just something that you can get a start with or work from. I thought it was interesting. A lot of stuff that we don't necessarily need. You would want to go into more disease processes on some of these outside lines um, than what is on here. But this first little bit is certainly a good start, and you wouldn't need to follow the leukocyte for now. You would want to do that in the next unit that we're going to study. But certainly interesting place to start. So make it fun. Draw yourself pictures. Put a picture of a kidney on here. Something that represents bone marrow. Get yourself the pre-information. Use colors so that when you're talking about iron deficiency, you use a light pink as opposed to a bright red. Things that help you remember what it is about that you need to know. And then, of course, you would want to go on to nursing process and, what kind of things are you going to assess? What diagnostics do you need? So on and so forth. That's going to help you determine how to care for a patient with disorders of the hematologic system. So that is the last slide, and anyway, thanks for listening. See you Monday.